Hello, everyone. My name is Bill Boysenalt, and on behalf of the Academy of Orthopedic and Physical Therapy, I want to thank you for joining us today as we continue to celebrate the Academy's 50th anniversary. Yes, 2024 is a big year for the Academy, a big birthday to celebrate. The first half of this year, I have interviewed a number of individuals who have played critical roles, key roles in historical events that not only shaped the academy, but also the profession wide. The goal of the second half of this year is to pivot and look at the next 50 years. Now that we're semi grown up, who do we want to be? What do we want to be like? And our first topic as we pivot to the future is primary care. Now, you could, with some legitimacy, say that primary care is not a new and novel practice area within our profession, but it is an area of practice that is rapidly evolving. And as a practice model, it holds unlimited potential for us as a profession, both in terms of practice as well as education. I'm joined by three individuals, three physical therapists who are deeply involved in helping advance the profession regarding physical therapists' role in the primary care model. So first, I want to welcome Ashley Castle. Ashley is the chief of outpatient physical therapy up in the Twin Cities area in the Minneapolis VA healthcare system, where she's been for 15 plus years. Ashley is also, if I'm correct, one of 6 subject matter experts working within the Veterans Health Administration to help embed physical therapists in primary care clinics across the country. Ashley also co-founded and serves on the board of the APTA's federal section primary care SIG. And part of her role is to is the project lead for the ABPTS petition to establish primary care physical therapy as a recognized area of specialty practice, as well as residency education. So Ashley, thank you very much for joining me today. Second, we have Dr. John Hike. John is a professor at Northern Arizona University within the College of Health and Human Services. In a previous life, John served in the Air Force, was a medic for, I believe, about 12 years, working primarily in primary care settings, primary care clinics. And John is one of 5 physical therapists at last count who is board specialized in 3 areas. For John, it's orthopedics, sports, and neurology. So John, I have to say, I felt like a slug as I read through your biography.
No, I've seen yours. Quite impressive.
John has a number of publications related to PT and primary care, differential diagnosis, medical screening. And John also is co-editor of the Goodman-Snyder textbook, Differential Diagnosis for Physical Therapists, the 7th edition. And one of John's roles within the Academy is spearheading the creation of a monograph on primary care. So I look forward to hearing about that. So John, thank you for joining us.
Thank you.
And then last but not least, Dr. Evan Kelly. Dr. Kelly is a retired U.S. Air Force physical therapist. As part of his role, he ran both large and small physical medicine clinics stateside, overseas, as well as in deployed settings. Evan is currently the Associate Chief of Sensory and Physical Rehabilitation Services at Manchester VA Medical Center. And Evan is also one of the 6 subject matter experts working with Ashley and others to spearhead embedding physical therapists in the primary care settings, again, throughout the VHA nationally. And Evan also is currently the chair of the APTA Federal Section's Primary Care SIG. So Evan, thank you very much for joining us. So to start our conversation, get an idea of your experiences and what brought you to where you are today within this area of practice and education. Ashley, we'll start with you. Maybe describe your initial exposure, introduction to primary care and the potential for physical therapist role responsibilities.
Yeah, absolutely. You know, as you had mentioned, I've been a physical therapist within the VA for a little over 15 years. And it was around 2017 when we were having the discussions of embedding physical therapy in primary care. Immediately, I knew that that was something that I was interested in. During my early years at the VA, I'd always wanted to have more collaboration and really establish stronger relationships with not just the primary care providers, but the rest of the team working with these patients. I really hungered to work in a multidisciplinary team like some of my colleagues did within the rehab programs. And so I was one of the first PTs in our region to be embedded within primary care. And immediately I really loved it. There were definitely some learning curves. It was really high paced, but I liked that. And it was challenging, yet I felt very supported. And just the doors that opened by being able to have those curbside conversations and build those relationships with the rest of the team was eye opening. It was just a game changer for me in my career. Um, and I would never go back. So, practicing in primary care PT for a few years before then transitioning into more of an administrative role. And so now have some experience with developing programs, starting programs throughout the VA. And that just kind of snowballed my passion for this area of practice. And then diving deeply into the SIG and the petition has just strengthened that energy.
A labor of love, right?
Yes, indeed.
We'll hear more about that. Evan, you're also currently in the VA system. Let's go to you next. How did you get introduced to primary care?
Well, actually, in the military, it is not new to the military. The military's PTs have been practicing at the top of their licensure for decades upon decades, providing direct access. I got used to working in a healthcare realm in which PTs were doing musculoskeletal sick call, in which you're actually seeing those that need immediate help with any kind of musculoskeletal or functional impairment concern before they see any other providers, or maybe the only providers that they see. But working, the military, as John will say, it's all about teamwork. When you go to basic training, nobody is doing anything alone. And that model just works well in the healthcare system. We know team-based care is the best care, regardless of what kind of care you're delivering, whether it be in a spinal cord injury clinic or a primary care clinic, whatever. And so it's just kind of like in our DNA, if you will. I really noticed it, believe it or not, in a deployed setting where you are working alongside physicians, medics, RNs, and who is the right person to take care of that individual in front of you. And often it's a physical therapist in collaboration with other providers. And so again, it gets back to that DNA. And I really think a lot of PTs have it in their DNA anyways, regardless of how they're exposed. We like to work at the top of their licensure. So when I went to work for the VA and looked at the models of care, specifically coming out of where Ashley is working, it was a no-brainer to jump on board, as well as to get involved with the APTA Federal Primary Care SIG. It's, as you had stated earlier, it really is the future. So my past is really going into the future. Here at Manchester, we have introduced primary care PT within not only a satellite clinic where it was a PT desert, if you will, but now our veterans have access to a skilled physical therapist in a rural setting, and then in our main campus here. So I'll go straight from here right up into primary care and provide a service that when you hear a veteran say, wow, I got seen today, or wow, this is the best care I've had in a long time. It makes you a convert pretty doggone quick.
Yeah, it's very rewarding. Very rewarding. Good, thank you. John, how about you? Your initial exposure.
Yeah, you mentioned my experience as a medic. So before I became a PT, I worked in a primary care clinic in the middle of Oklahoma, and then moved on to do aeromedical evacuation, which is techs and nurses together in a team-based approach, taking care of the patient on the back of the plane. And so I did that for, as you mentioned, 12 years. As a physical therapist, then I was able to work at in 2000, the PT journal, the PT magazine featured an emergency department physical therapist, and I worked at that hospital, St. Joe's in Tucson, Arizona, to administer emergency physical therapy, which I feel is part of the idea of where we're going in terms of primary care. We're best suited to do that. We're musculoskeletal experts. People that come in the top two most common complaints are dizziness and low back pain, and that's what physical therapists do. So my experience there allowed me to see from a very broad perspective of all the things that we could do for primary care.
Right. Very good. Very good. Well, each of you have kind of addressed this to a degree, but maybe a little more in depth. And John, we'll start with you this time. Kind of describe PT, our role in the primary care model regarding today's practice before we kind of look into our crystal ball. What else are you seeing or experiencing out there in terms of today's practice?
I think in today's practice, besides the VA, besides the military, I don't see that there's a lot of physical therapists that are in this area for primary care, but I see the potential for that. For Flagstaff, I live in Flagstaff, Arizona. We do have an emergency department physical therapist. In the VA setting, we do have primary care teams. In the military, of course, we're able to practice at that level. I don't see that happening a lot, and I think there's the potential for that, and that, of course, leads us to the future. But does that help answer your question?
Yeah, and that'll fit into a question coming up in terms of what challenges are we facing? How can we transfer the military VA model into the public sector, more completely?
Right.
Evan, how about you in terms of anything else to add regarding today's practice?
Yeah, so I mean, really, when we're looking at PTs, and John's right, really, it started, Carlene Jadolka, you know, probably 10, 15 years ago, started getting people right into emergency department, which made perfect sense. We know the sooner we intervene on any intervention, the outcomes are just better. But when it comes to PTs and primary care, really, we're seeing that PTs are becoming just more integrated and accessible and more holistic patient care, and really looking at comprehensive wellness. What we like to say in the VA is, when we see you in the primary care setting, is, can we get you on the path to wellness within 1 to no more than 4 visits, as opposed to this standard episode of 12 visits? How do we use the word wellness a great deal in that environment? Triaging, diagnostic and management services within primary care to really help that pathway for those individuals with physical and functional impairment needs. And one thing we say is that primary care PT has this ability to work across multiple specialty areas, multiple body systems across a lifespan. And really, you're looking at a clinician who has a skill set that's 3 feet deep and 3 miles wide. It's kind of like, has to be that clinician, Jack and Jill of all trades, to be able to really go in and work in that environment. And everything from medical psychosocial screening. Does this patient belong here? Are there yellow flags? We all know about red flags. Is this person best suited for physical therapy? Or often in that primary care setting, saying, what, this person really needs to see this specialist. Let's help facilitate that. And or can we do this in conjunction with this specialist? So it's pretty broad. So that's a pretty broad definition, but 3 feet deep, 3 miles wide, we're good at it.
Yeah, well, you're right. That does kind of sum it up. Ashley, how about from your perspective?
I would add a couple of things that we see that are maybe a little bit unique in primary care roles would be the sustained patient relationships. So oftentimes in a traditional outpatient clinic, we may see more of a linear and finite relationship that begins with an evaluation and ends at discharge. And a lot of times in primary care, we're seeing more of that ongoing revolving door model where a patient can come in and out of care as needed, with perhaps more of a focus on wellness and chronic disease management. Um, Care pathways, being integrated within the primary care team, ideally co-located. That's not always possible. So along some spectrum of integration, from even virtual collaboration to physical co-location at the other end, with some some examples of care pathways would be a warm handoff model, where maybe the PT is physically co-located and the physician might just come knock on the door. Hey, I've got a patient. Can you see this person? Or perhaps they're seeing the person together. And then also a direct triage model or some combination thereof. Even within VA, we're seeing both of these different kinds of models. We're seeing hybrids of these two things. And so we've really encouraged, we've got this template of what we think and what has been shown to make successful models within VA. Um, but then recognizing that it's going to be a little bit different depending on the team and the resources and the demand at each facility. So I think that truly would be true to clinics within VA and outside VA. So in addition to that really broad scope, I think there's that emphasis on wellness and disease prevention and really that sustained relationship, which is a little bit unique.
Yeah, agreed. One of the things I've heard over the years that it's kind of a myth, people equating primary care with direct access. And each of you mentioned briefly about PTs maybe being an entry point for selected conditions, but that was not the focus of what you described as the current practice model that you're involved in or that you have been involved in. It goes way beyond the direct access model. Well, you've answered this to a degree already, but as we kind of pivot and look to the future and primary care practice and PT's involvement, besides trying to get it more translated into the public sector, what are some of the other challenges, or what is the big challenges that's preventing it from taking hold in the public sector? And actually, we'll start with you. I mean, you're in the VA system, but you're aware of what's going out there in the public sector as well.
Yeah, absolutely. I agree with you, Bill. I think that's one of our biggest hurdles is how can we spread this in the public sector? And one of the biggest challenges that we hear from folks is related to the payment models. And so I think that's the big gorilla that we need to deal with. And whether we're dealing with capitated systems where there's an incentive to get better sooner, or non-capitated systems where the healthcare system is going to want to bill whomever can generate the greatest revenue. Um, I think there are some things that we're hearing that are working well at certain sites outside the VA. So there's some options of billing incident to the primary care provider. And also, there are some clinics that are lending a PT to the primary care clinic because they've seen higher conversion rates for PTs into their outpatient clinic. I know Bellin Healthcare System is one example of that. I can't remember exactly the percentage, but I think it was somewhere around 37% increase in referrals to their outpatient clinic using that model. Something else that could be explored would be collaborative care model codes and what might that look like within primary care PT. I know that's something on our radar within the primary care SIG to look at a little bit more. And then also just noting that the traditional insurance payment model is not the only option. Self-pay models and member subscriptions are becoming more popular, but certainly recognizing that payment models, I think, seem to be the primary barrier from what we hear from folks outside the VA. Certainly also, variations in state practice acts and really trying to get some uniform legislation so all PTs can practice at the top of our training and scope, especially in a primary care setting, I think will be really important as well.
Yeah, payment always comes up. It always comes up. Evan, the discussion within the VA started about 7 years ago. So it's taken 7 years to get the VA where it is today. And I'm sure there are some budget ramifications for embedding PTs. So how did you overcome those challenges internally?
Well, that's a really good question. What we have found is, and let me back up. It's a cultural shift, even in the VA. There's a paradigm shift in how we're delivering healthcare. And so not only within those primary care teams, who may really think that PTs are down in the basement somewhere and we're not quite sure what they do, but they walk in broke and they walk out fixed. And so it's changing that perception of what we do, especially when we work side by side in collaboration with them. But when it comes to the fiscal aspect, one thing that we run into is, okay, how productive is this clinician going to be? And what are the benefits of having that clinician there? We have seen not only in the VA, and we're able to prove within the VA, but it's also been seen elsewhere in other writings outside the VA, in the UK, in Europe, et cetera, that we're able to prove that we help decrease downstream costs. So one downstream cost having to do with specialty clinics. When that PT in primary care is involved at the onset of care, there is a decrease in orthopedic referrals because the PT can manage a lot of them, podiatric referrals, chiropractic referrals, and we actually have developed a dashboard within the VA that actually show these numbers. We actually have evidence to show that we are able to decrease those downstream costs. So those who are in charge of the purse strings that actually give us the actual numbers and full-time employees, the FTEs, we're able to show there's that benefit. Also, decreased utilization of imaging. I am in constant communication with our chief of radiology, who loves PTs, and he's not the first chief of radiology, loves to have PTs as the ones who are actually ordering the imaging. We know that PTs are far more judicious in their ordering of imaging. And so by having PTs in the outset, you actually decrease the amount of utilization for diagnostic imaging, and not just x-rays, but MRI, CT scans, et cetera. But that then helps with the availability of that imaging, which is a finite resource within your healthcare system. So now patients who truly need to have that MRI can get in much sooner. But we're also able to show that when we have those PTs embedded in primary care, the cost utilization of that PT, we found that if a patient has to be seen outside the VA, there's a certain amount of cost. If we can recapture 100 unique individuals, that pays for a PT. So what we can do is what we call its FTE, or full-time employee neutral. That is, we can take a clinician out of standard outpatient physical therapy clinic, move them up into primary care, and it's almost like a force multiplier. That is, instead of all those consults and people waiting 3-4 weeks to be seen down in primary care, when they're seen early on, fewer visits, less downstream costs, but then on top of that, what we're actually able to show those that have the purse strings, that patient satisfaction goes through the roof. Provider satisfaction goes through the roof. So we have tangibles to show, yes, we benefit. And then we have those things, those soft skills that really would make a healthcare system great, not just medical care, but great care in itself. And it becomes a no-brainer. But sometimes it's communicating with those that control the purse strings can be a real challenge, because it's a paradigm shift for them. For them, this can be very foreign. But once we get going, or if they become a patient, we have converts. So.
Yeah, I don't wish ill on people, but I enjoyed getting a physician or an administrator as a patient. I had that kind of a captured audience, not just to provide the care they needed, but also to educate. And you're right, many of the people are in control. They're not physical therapists. And so they don't know what our training is and the history is. And so, it's an opportunity to educate folks out there, the decision makers. So, John, we have payment up near the top, changing a culture. Anything to add regarding those two, or anything in addition that seems to be such a big challenge for this carrying over to the public sector in particular?
I think the other thing would be advocacy, in terms of looking at advocacy. And with advocacy, there's education that's involved, right? And it's to that hospital administrator. We do have examples. Kaiser Permanente, Ivan Matsui, for example, and his team has disrupted. And when I think about advocacy and primary care, it feels like I think of Christensen's book about the innovative prescription, right? It's coming in and trying to disrupt the healthcare system to change the current model, and advocate and educate the administrators, and as you said, Bill, the physicians as well to say, this is what we offer, and give examples to make sure that they have a pathway of, okay, what did you do? What were the challenges, and what were the barriers? How did you overcome those? So, Kaiser Permanente system, the VA system, and making sure physical therapists know it so that they can then go and approach the administrator or of a hospital and try to advocate and educate them on what we offer. They don't necessarily know that. And so I think education would be the other part of that. It's been said, but I think that would be the main focus.
Yeah. And John, speaking of education with your students at NEU, what kind of experiences or exposure are they getting when they're out on their clinicals, if any, that you're aware of?
Yeah, so they have the opportunity to do a clinical rotation in the emergency department, and that's just one, and of course in the VA, and so that's a potential. But the other thing that occurs in more rural settings than in urban settings is that, if you're in a small town, you are all of those things. There's not an athletic trainer in that town in Arizona, for example, or across the West. Right. And so we as physical therapists become the primary person and try to do that holistic care. We don't have as much of a team base if you're the only person to care for the community, but I think that's also a possibility.
Yeah. Yeah. Good. Ashley or Evan, do you know how many students do clinical rotations? I mean, DPT students do clinical rotations through the VA system nationwide?
That's a great question. Last I looked, there were 35 plus sites that were offering clinical rotations within primary care. I don't know, what number that translates to, because a number of facilities will take multiple students each year. So with the diffusion program that we're working with right now, we're hoping to see that number rapidly expand.
Yeah. And what a great experience for the entry-level students to have, and what great role models this system would be, to help the graduates then become change agents, out in the public sector, if that's where they end up practicing. So
Yeah.
Yeah,
I think it's good to note too. We talked a little bit about education, but also changing the culture, and really educating our colleagues and providers. And one thing I just want to highlight that we've done in the VA that I would love to see happen outside the VA at some point is a multidisciplinary team-based training. It's really tough to pull providers and nurses out of the clinic, but it's been so successful that we've had really good support for this. We've held a couple trainings at the Orlando VA at a simulation center where we've had teams across the nation representing all the different regions of VA. And those teams include the primary care provider, an RN, and the PT. And so, really talking about successful programming, building relationships, communication plans, and then identifying roles and responsibilities. And then we're also running them through simulated cases. And so we can really highlight what PT can do and how we would supplement what they're doing. This isn't a turf thing. We're not trying to take over. We're trying to help to the best of our ability. And some of the comments at the end of that training have been from our providers is that this completely shattered my view and changed my view of what I thought PT was and could do. And they're saying these things over and over again. And it's just been so successful that I would love to see something like that spread outside the VA, because I think that could help a lot with the advocacy and the education. But again, it's challenging to pull those busy folks out of clinic.
very, yes, very. But you're right. If we could bottle that, it may make a huge difference. So in terms of resources out there regarding primary care and potential PT role, Evan, you're currently the chair of the primary care SIG for the federal section. Can you describe some of the resources that the SIG has created?
absolutely, and not just the SIG. I am going to put on my VA hat as well, because on the VA side of the house, I'm going to start with the VA, and then we'll jump to the SIG. Our initial intent and our mission was to get a physical therapist within each healthcare system in the VA. So a healthcare system would be like a VA medical center, by the end of fiscal year 2025. But we realized that doesn't happen by accident. And not only, I mean, you just don't pop a body into an exam room, sprinkle a little fairy dust and say, there you go. You need to make sure that they're trained, they're successful, and there's a succession plan. So we have created 8, 9 different primary care specific contents in partnership with the APTA, in which clinicians can see everything from TMD screening to vertigo to even how do you combat burnout. And we continue to develop that content. On the SIG side of the house, we have a national mentorship program. So in addition to having regular information having to do with abstract of the month going out, trying to get dialogue with different clinicians, we actually have a mentorship program to where we're matching skilled clinicians with emerging clinicians, not just students, but those that are brand new to the profession. And we found that to be very successful. It's not as big as we would like. We would like to have more members and more members that join the SIG. So if anybody's listening, I hope you're listening and interested, go to APTA Federal. Okay, you can actually join any one of the SIGs, because once you join Federal, you have all these other great special interest groups at your fingertips. But the larger the numbers we have, the more talent pool that we have for developing content. We have just changed over to a web-based system as opposed to what was called Basecamp, in which we'll be taking content that we've already developed, different webinars and ongoing development of webinars specific to primary care, and having that available to those members. We've had folks like Aaron Keel give presentations, Todd Davenport. We had Rachel Wellen out of Louisa State University and her team give an incredible presentation on vestibular care and assessment in a primary care setting. So all these webinars are really focused on that initial point of service delivery. Now, they're good in an outpatient setting, absolutely, but it's that initial point of contact when that person just shows up, giving them the skill set that they need.
Yeah, very good. Very good. John, I'll go to you next. What resources do you steer your students toward, and other resources that you have found helpful over the years as well?
Yeah, I think Evan mentioned the red flag. So I think number one, knowing and using the OSPRO ROS and the OSPRO YF for yellow flags, and in terms of recognizing those things, in terms of differential diagnosis, of course, your textbook, as well as the differential diagnosis textbook. I think being able to differentiate between the different conditions, that's, you're seeing, like Evan said, something, all of these different conditions are going to walk in, and potentially you need to know how to look at those and be able to determine what systems are involved. So it's more of a systems-based type of approach to be able to say, it's this versus that. So trying to emphasize differential diagnosis, and we've seen that in terms of the board exam has increased the number of differential diagnosis questions as well, because that content has continues to rise up in terms of being able to treat all of those different potential conditions. So I think those resources are very helpful in terms of recognizing those red flags, but I think we also need more.
Yeah, and that recognition ties into the PT's ability to, order imaging or a battery of lab tests, just again to speed up the process of getting the patient the care that they need. Actually, how about you in terms of your effort within the VA or just your own personal practice? What type of resources have been useful to you?
Yeah. In addition to a lot of the things that were already mentioned, there are a lot of really great courses and content on the APTA Learning Center, and there have been numerous courses relevant to primary care PT added within the last couple of years. So I think that's an excellent place to go. And also CSM. Primary care has been really a hot topic the last few years. There's been a lot of presentations and content related to primary care, but also the networking. Come to the primary care SIG meeting, for example, meet people. If you have questions or are running into barriers, learn how other people are handling it. And the other thing I wanted to highlight is something that we've created within VA, and now the primary care SIG is looking at replicating this and making one that would be universally relevant to folks outside of the federal sector, is an implementation guide. Because not only do we need resources for clinicians, but how do we do this? How do we get started? What should the program look like? What does success look like? And so we've built a pretty great, I think, implementation guide within VA that includes things like how to talk to your leadership. What's your elevator pitch? Here are some ideas of what the program might look like, and then these are kind of some absolute must-haves for success. Who might be a good fit for a primary care PT, because it's not the role for everybody. So, what qualities to look for, what questions to ask in hiring. So, we've really included all of these things within a packet and recognize that that needs to look a little bit different for it to be relevant for folks outside the federal sector. And so, that is something that we have in our strategic plan that we'd like to work on within the SIG. So, not a resource that's readily available right now, but looking to build that because we certainly recognize the need and the value.
Yeah, I think that'll be key. Whether we're talking about legislative approval of different language in our Practice Act or a health system approving this kind of model, that ends up being the easy part. Because again, you're changing a culture. So implementation into daily practice is a huge challenge, or filled with huge challenges. And so having some resources related to that, I think would be really, really helpful. Actually, you're the project lead on the ABPTS petition, as I mentioned before, in trying to establish primary care PT as a recognized area of specialty practice. Why is that important?
Oh, that's a great question, Bill. First and foremost, I think this is important because it really creates standardization for advanced competencies and training requirements to really achieve that highest level of training in this area of practice. That's the most important. I think with that comes validation of knowledge and then also enhanced credibility and trust, not only amongst our peers and colleagues, but also amongst the primary care teams, our patients, and really society as a whole. Um, so I think, overall it helps to validate and then really to demonstrate that level of education and training within the primary care realm.
Yeah. Can you describe the current status of the petition?
Yes, I can. So, just a brief kind of history for folks who may not be aware. This it's been a long process. Phase one of this petition was spearheaded by APTA members and was approved in the summer of 2020. Our primary care SIG took over leading phase two of this petition in 2021. It was at that point when we were reviewing the evaluation report from ABPTS and ABPTRFE that a supplemental and full revised practice analysis survey was needed to identify some areas that weren't quite addressed yet. And so that was fielded and completed in March of 2023. We submitted our phase two petition last November. And we recently heard back from the Joint Review Board that some, but not all of the requirements successfully met the expectations. So, while this is somewhat disappointing, I think it's really great. It does signal, success in moving forward and next steps. And now we know there's a few more things that we need to look at and revise. And we're getting the band back together, the subject matter expert work group, within the next week or so. And our goal is really to get this resubmitted this fall. If and when this gets approved, there would then need to be a 90-day period for open public comment, after which point there would need to be an open hearing before we could submit this to the House. So we're moving forward, and all of you on this call have been instrumental. So really a huge shout out and thank you to your contributions.
Yeah, well, thank you for leading the effort. It is a huge effort, with the phase one being approved. So it's been recognized there is a need, right? And there
Correct.
is an audience out there large enough to warrant further exploration for this. John, from your perspective as an educator and for your students, if this becomes an area of specialty practice, I mean, what kind of impact might that have?
I think it'll have a big impact. I think it's rural. I think it's urban. I think potentially it's a new place that physical therapists can work. So if you think about emergency department, you think about urgent care, you think about VA, you think about that occurring in a rural setting, that occurring in more of an urban setting. I think it's just going to be beneficial for all of our patients to be able to practice at that level. And we have the skills, we have the education, and we just need to educate others on it. And so I think it's going to be a very, very big impact to provide an additional practice area or niche or setting to be able to do that. And maybe an individual as a student, I've always said, maybe their main job is this. Maybe they're working in an orthopedic clinic, and then they're working additionally, I don't know, 6-7 days a month in this primary care clinic, or maybe they just switch that and they primarily work full time in that primary care clinic and do some time in that outpatient ortho clinic, and so the skills I think transfer very well. I'm super excited about all of these possibilities.
Yeah, yeah. Evan, we'll start with you as kind of our final round robin here, and just final thoughts, whether it's current practice, challenges, where you see this heading down the road within the VHA system, but also beyond.
Sure. And we've talked about culture shift and paradigms, and one thing that we have actually codified, if you will, within the SIG as well as the VA is, what does the future look like? What do we want? And specifically, for the SIG, it's really physical therapists are universally recognized as frontline providers in the primary care arena. That simple. And on the VA side of the house, we want to really promote the integration of physical therapists within primary care across the VHA to maximally contribute to high value healthcare for all. And so with that, those are lofty goals. And so what I see is, it is going to continue to spread across the VA. The Defense Health Agency and the DoD, with the paper or actually the report that went to Congress in January of this year, pretty much stating not if, but you will start recognizing PTs, physical therapists, as primary care providers within that healthcare system. And so I think what's going to happen is it's going to be harder and harder for other large healthcare systems to ignore PTs within primary care. There's always a question of safety. We're going to have more and more data showing not only are we very good and safe at what we do, but there's true value added for every aspect within the healthcare delivery system, not only to the patients, but to all those team members, to the providers, to the administrators, the frontline staff. Then that pressure is going to kind of build up for those that are going to advocate for different practice acts within the different state houses, where you're going to have PTs marching up. And, when it's, PTs up on the hill kind of deal, you're going to see more and more of this inertia to where ultimately what we're looking at is PTs in primary care is just going to be a standard model of healthcare. It is going to take time. It is going to take work. The petition, that's a huge lift, which is already being done. But really, that's where we're going, and it's no turning back at this point. We've proven it time and time again. Now that inertia is just going to groundswell, and it's going to work its way down into academic institutions where you will have primary care specific coursework. So the future is great. It's just got some work ahead of us in time.
Yes. Ashley, how about you? Final thoughts?
I would really like to see, and I think this is coming, more publications on this, more numbers, more data. I think that will help folks outside the VA to speak to their leadership and support this, more educational content, and really, a vision, of course, for a successful petition. And as a result, hopefully growing numbers of post-professional training opportunities. I think that will be really huge in this realm.
Yeah, very good. And John?
I'd like to see academies come together. in terms of primary care in the federal section, I think that if we were able to bring the academies together to support this movement, we could advocate a lot better as opposed to just having one academy approach something. So, for example, imaging. Primarily it stays in one academy, but we have lots of people that are potentially using it, talking about how wonderful this tool is. I think we could get academies together to work together, and then we would have the masses, we would have the people advocating, we would have the education piece there. I think that's a very important piece to making this happen.
Yeah, that would allow for a consistency of message and not reinventing the wheel over and over and over again. So, well, listen, the three of you, thank you very much, not only for carving out time today, but all that you're doing to help push forward this initiative. Evan, as you mentioned, the more work we do, the harder it will be for others to ignore, what we can offer within this kind of model. So keep fighting the good fight. And again, thank you again.
Very well.
Thank
Appreciate
you.
the opportunity.
Yeah.